Almost made it. We'll see if this works. 5 days in the snow, how are we feeling? Yeah, bodies holding up. Seen a few crutches, a few people hobbling around, a few arms in slings, but I think all in all we've done alright. We had a pneumothorax a couple of years back, so we haven't had any of those yet, so that's always a bonus. Don't jinx it. I'm just going to swap mics. Bear with me for 1 sec. So today we've got 2 presentations. We're going to have Robyn coming back, we'll have a little bit of a break, and then we're going to have Sam to finish us off talking about some trauma. You may have noticed we've had to drop down on our bottle policy. So there is still lots of wine outside, so please feel free to go and fill the glass up. But yeah, we ran out of wine, so Dylan and I went across to the Seiko Martin 7-Eleven, and now they don't have much wine left either. So yeah, if you saw us trying to cross the road with a snowboard bag full of wine bottles, you should have stopped and given us a hand because it's hard work. But you guys done a great effort getting through a lot of bottles of wine, so I hope you guys enjoyed it. But it is what it's all about. So let's get into our first presentation. I'll have a bit of a chat then in the middle break just about the details of the closing party, and then just some things about certificates and e-learning. But for now, let's give Robyn, our first presenter, a nice big round of applause. Thank you, Robyn.
Thank you. Thanks, Quentin, and hello again, everybody. So tonight I want to talk to you a little bit about AI. AI is very ubiquitous, it's everywhere, and overall I'm reasonably positive about it, to be honest, but there are some things that we need to talk about, so let's get into it. I wanted to start by telling you about a project that we're doing with the Australian Institute of Health and Welfare. It's called NISA, which is the National Injury Surveillance and Reporting Project. And what it's doing, it's an AI system that's sucking up all the data that you collect in the ED and using AI to interpret that data in terms of national injury surveillance. So it's going to understand patterns of injury across Australia, and that understanding of the patterns of injury will then help inform national and state injury prevention programs. So we've just started it, but you'll hear probably more about it if you're from Australia over the next year or 2. Now, sounds great, doesn't it? But AI is quite complex and the devil is really in the details. So I just want to give you an example of what NICE is going to do, and we can talk a little bit about what some of the issues might be. So for example, on the left, we've got what we currently have in our system. So you might record age, sex, type of injury, the ED length of stay, the transport mode, and all the medical notes that you make. What NICE is going to do is it's going to take that information and use AI to interpret it, and it will come up with things like the injury intent, whether it's intentional or unintentional. You know, was it an assault? Was it undetermined? It'll have the place of occurrence. It will have the product that contributed to the injury, whether there was substance use or misuse involved. Was there a perpetrator? And any activity at the time of injury. So now from an aggregated data viewpoint, there's really no problem with that. But imagine you in your ED, this can identify someone who's abusing their child. This can identify domestic violence, for example. So is that going to change the types of questions that you ask your patient when they come in, knowing that this system is going to identify that, and knowing that if it does identify that, are you going to have to be mandatory reporting that? So even though it sounds like a great system, and hopefully it will be, nationally, for the individuals at the individual ED, it's a little more complex. You know, when people know about this system, will patients be nervous about giving you the full report of what happened and why it happened, knowing that these things can be identified? So that's just an example to just sort of illustrate some of the complexity that we can see in AI. I just want to talk about where it's being currently used in healthcare, because honestly, it's all over the place. There's pockets of it everywhere, but there's very little of it that's integrated or that talks to each other. So we're seeing it in diagnosis and prediction. Most of the imaging process now uses AI, and it actually does a better job in general than the people do. Dermatology as well. It's being used in decision support, gives treatment recommendations and medication management. It's being used in remote monitoring, so patients wearing wearables, for example, particularly in things like hospital in the home. It's being used in healthcare administration for scheduling records and data management, And in the US, probably the biggest use of AI is in billing. So it's being used in robotics. We already know about surgery and the Da Vinci tool, and for home support, and especially the consumer. There's a proliferation now of consumer apps that use AI, but it can be used for patient engagement and patient education. So lots of different applications, and often you're not going to be aware that there's actually AI in that device or piece of tech, but it's often there. So how good is the technology? Is it really up to speed? Because we hear good things and bad things about it. So there's many advantages, and it's rapidly improving really, really quickly. But it does also have some key issues to consider. So data privacy and security, for example, are people consenting to having their data being used in the AI system, and how is that data being stored? What about bias and fairness? So are there representative demographic backgrounds being used in the data that's being used to treat people? So we saw it with medication testing, you know, in the last couple of decades, where most of the medications have been tested on males, adult males, and yet the medication's being used on older adults, and it's being used on females. And it's the same sort of thing with AI. A lot of the data that's going into the AI is being from non-representative populations, and also the AI itself has been designed generally by men between the ages of 19 and 25. So the way the data is manipulated has a certain inherent bias in that as well. There's a lack of transparency. It's like a black box. Everything goes in and something comes out, and you've got no idea what's happening in the middle. And that makes it very difficult for you to be able to judge whether what it's telling you is actually correct, or whether it's what they call a hallucination, so it looks correct, but actually it's not correct. And there's regulatory and ethical concerns, particularly in terms of accuracy and also in terms of equity of access. So the major one that I see, though, is the lack of integration. So there's a large gap between the availability of AI in all the different places where it's being used and the ability for all those systems to talk to each other. And we see a lot of issues because of that lack of integration. So just a few cautions. Beware of over-reliance on AI. We find that the caution people usually use in terms of new technology, because AI is so easy and it looks so cool, people are not applying that level of caution. Just to give you a couple of examples, I went on to a couple of the image generators and asked them to produce a picture of a hospital emergency department, and this is what I got. So you can see image generators can actually generate the image that looks a little bit like an ED, but they're no good with text because they think of text as an image, and you can see they can't spell emergency on any of those. So, the two on the left are from DALL-E 2, which is one of the original image generators. The third one is from DALL-E 3, which is probably state of the art for the DALL-Es, and NVIDIA, which that one's only a few weeks old, so that's probably state of the art in terms of image generation using AI at the moment. So yeah, so caution, beware. And use it wisely, but check everything. So they generate responses that appear correct, and it looks great, and they can give you references and everything that tell you it's correct, and it could be complete bunk. And we saw earlier this week that one of the Australian lawyers was caught out with this, immigration lawyer, used ChatGPT to file the cases, and they were just completely made up, including all the references. So, so that person is now in trouble, I guess. So, and I mean, with a lawyer, it's really just embarrassment, but with a doctor or a nurse, it could be life or death. So it's, and the time when you need it, when you're in a hurry, is when you're not going to have time to check the system. So, are our systems ready for AI? This is an example from one of my research from a couple of years ago now. We used AI to develop algorithms to identify doctors at risk of medical malpractice or impairment. This was for the New South Wales Medical Council, so anyone who's from New South Wales. So we identified the evidence based on risk factors associated with medical impairment or malpractice from the literature. And we developed machine learning algorithms to be able to detect whether there was the prediction of a medical practitioner receiving at least one complaint. If they received one complaint, were they likely to receive an additional complaint? and if they were being monitored for poor performance or impairment, would they receive additional complaints? We used all of the data on their database, and it was quite an accurate algorithm, and it was going to improve the management of doctors in New South Wales because at the moment it's manually managed and there's issues with it. So great, all good to go. We were meant to put it into their new system that they just bought 12 months ago, 18 months ago. When they went to buy it, they decided it was too expensive, so they cut out the AI component. So it can't be implemented now. So they're back to doing it manually. So it's fine to say we can do AI, but we need to be able to have the system that allows us to be able to use that AI effectively. So healthcare's never been the best at integrating new technologies into current systems. My primary field is the field of human factors, and a lot of people in healthcare think of human factors as the human factor, as in the human as the person that, is their limitations is what causes the error. The field of human factors isn't about that. The field of human factors is about designing systems so they better meet the needs of the human that's using them. So you want to have a good fit between people and their environment, and you don't want to change behaviour. If you've got a well-designed system, people shouldn't have to change their behaviour. They should be able to use that system without having to really work at it or have a lot of training. So good versus bad design. Good design, it has to be fit for purpose. So if you have a look at the cup there, the cup handle, not really fit for purpose, can't get your finger in. And the plug, that particular plug, anyone who's got an Apple system will have run across that before, where the outlet's so close to the skirting board you can't actually get the plug into the outlet. So not fit for purpose. And it should be intuitive to operate. So those two things, if you looked at the lift buttons, which button's up and which button's down, how do you decide? And the door, how many times have you seen a push door with a handle on it? So if it's push, it should have a flat plate for push, and a handle should indicate pull, should be intuitive. So our systems are not like that. So take, for example, how many of you have got these in your EDs, these automatic pill dispensing machines? Yeah, a few people will have them, I think. Yeah, so the pharmacists love these things because it automatically tracks everything. So it can track how many medications are in there, can notify them when the stock needs to be replenished, tells them when things are out of date, and it's good security. So you've got to actually prescribe. So you have to go into the computer, prescribe, and that will magically open the appropriate drawer and you can get the medication out and take it to the patient. We had a look at this in one of our EDs, and honestly it was much faster to get the S8 drugs out of the cabinet, and they're still locked in a cabinet, the S8s, than it was to get the paracetamol out of one of these. So what actually happened is that we were watching, and the nurses, when they get it open for paracetamol, instead of taking the 2 tablets, they just take the whole packet and put it in their pocket and walk around, because it just takes so long to get into this system. So you can end up with workarounds. So it's not really fit for purpose in the ED, even though it might be a great design in a ward where it's not time critical, and it's not really intuitive to use. So we can, when we're talking about bringing AI into healthcare and integrating, we can use those same human factors ideas in that the AI should be fit for purpose, so it should do what it's meant to do, and it should be intuitive to use. You shouldn't have to have all this difficulty and all this training in order to be able to use it. So we need that same human factors approach to design that we use for other technology. Now, if you are integrating anything into your system, there's lots of information out there on how to do it and what other people have done and what's gone wrong, so that you don't make the same mistakes. So if you're trying to put a new system in, get onto Google Scholar, put a few keywords in, and you'll have heaps of papers will come up and tell you how other people have done it across the world. So one of the issues with AI that we found is that it really does need some governance. This is both to protect the patient, to protect the staff, and also to protect the system. This is quite a good paper on that QR code that talks about this type of governance in detail. But essentially, you need patients, clinicians, and staff to be involved with how it's being implemented for patient safety, and to make sure that people understand what the black box is and how it works and how to adopt it. You need operational governance in terms of making sure that it's integrated into workflow. And you need leadership governance in terms of making sure it's endorsed by leaders and that there's plans that involve in looking after this thing. So, and I'm wondering also whether we need some ethics oversight on it as well, because there's a number of issues that have arisen where ethics has been a consideration. So what sorts of things might you want to think about with adopting? Really, the first one is to consider what it will offer to the system as a whole. So we often get things implemented that work for our little bit and don't think about how it fits with the rest of the system. So does it add value overall, and are there unintended consequences if you implement it over here to the people who are trying to work over there? We need to integrate it with existing systems, and don't adopt now and integrate later. If you don't integrate it from the start, it will never be integrated, and you're going to be doing workarounds for the whole of the life of type. The AI should also have this user-defined functional specification that tells you what it's meant to do, not just what all the technical stuff is, like how fast it can do it and how much, what IT equipment it needs and so on, but how will it be used? Is it fit for purpose, and is it going to be intuitive to use? You need to consider whether training, education or modified workflows are going to be needed, develop an implementation plan, and especially ongoing funding. So any sort of IT system, whether it's AI or any other sort of IT, it's a bit like a printer. The printer's really cheap, but the ink's the thing that's expensive. In terms of IT, it's the software that's expensive. So if you get a bit of kit and don't think about funding it for life of type, especially something like AI that's going to grow and change, it will be redundant really quickly and pretty much useless. So consider sustainability, make sure there's processes embedded for ongoing evaluation and provision for growth. So as the system changes, this thing hopefully will grow with it. And you guys use simulation a lot. So simulation can be used to develop and evaluate that AI before you bring it into the real world. You can do it with new AI systems, you can do it with integrated systems, you can have a look at comparisons if you're thinking you might want this one or that one. You can look at failure modes, so it's a nice it's a low stakes way of looking at failure modes, and you can develop procedures for use without having to influence or affect the patient. So what are some of the promising applications that we're seeing in the ED? Some of these are from overseas, but some of them are from Australia. So what we're seeing within the ED is that AI is being used throughout the whole ED journey. So there's AI applications that will help consumers self-triage. Some of them are run through telephone systems and some of them are run through apps. There's AI systems out there that can give guided dispatch for the ambulance, for example. There's AI systems to assist with registration when the patient arrives at the ED. There's AI systems that can assist with triage. There's a plethora of AI systems involved with consultation and treatment. And there's AI systems that can assist with discharge and discharge home. So some of the consumer applications, it can be used for self-triage. We're starting to see check-in kiosks now. Has anyone got these in their ED yet? Some people maybe have. Yeah, so I'm not seeing any hands, so maybe not yet. Okay, so these are coming in. So enables the patient to check in themselves, do a lot of the pre-check-in themselves, particularly for Cat 4s and 5s, so people that have time on their hands and have got cognitive capability. There's applications for patient engagement, and there's applications for patient education as well. So you will see more of these as time goes on. And I've got up there Health Direct, which is the self-triage application, which people in Australia may be familiar with. We're seeing chatbots and robots in the system. So chatbots are being used to assist triage and early diagnosis. And there's a University of New South Wales team that are currently developing a chatbot to help triage for culturally and linguistically diverse adults. So it will help them, will just help with communication and triage with those adults. And in Singapore, they've got robots in the EDs to assist patients that come around. And the co-design work that we've done recently with the CALD group, they all want robots because they've seen them. So a lot of these people have come from China and they've seen these robots and they want them in our EDs. So we'll see how we go. The clinicians don't. They think they'll last 5 minutes and someone will kick it in and that will be the end of that. Anyway. So, and this one, AI scribes. How many of you are using AI scribes already? Yeah, okay, so quite a few people. So, one of the things that I talked about on Wednesday was that the difference between EDs, some of the EDs overseas and some of the EDs in Australia, that overseas they can be quicker because they may not have as many administrative processes. The AI scribes can help with reducing that administrative burden, which will then help you reduce the time it takes to see the patient. So the idea of an AI scribe is it generates medical notes from a smartphone recording, so you can come up to your patient, you can put your smartphone down, you can then ignore it and just talk to the patient, which is lovely. You have this nice interface with them without having to be looking at a screen the whole time. And it will send that information back to your EMR system, and it can then turn it into your medical notes, or it can turn it into plain language for the patient, or it can turn it into whatever you want it to turn it into. So it just alleviates the burden of you actually having to go back after you've seen the patient and type up all the notes. What it doesn't do though is you still have to check it. So it's not good enough yet that you can just sort of trust it necessarily. So it's reasonably new to our ED, although I saw probably a dozen hands up there of people that are using it. Are you guys using it with Epic? The Epic one? No? A separate thing? Yeah, okay. So anyone who's using Epic, Epic has a module for this that allows you to do it. The only issue is, I talked about how the New South Wales Medical Council didn't buy the kit for their system. New South Wales Health is vacillating about getting the kit for the Epic system with the new integration, so just beware of that. But it is available in Epic if you pay for it. GPs are using it a lot. Around about 20% of GPs in the UK are using it, a 2024 study. Anecdotally, my understanding is it's over 35% in Australia, but I don't have the paper to be able to give you the reference on that. So, but there are issues, like everything else. So the ED environment sounds great, but there's high noise levels. You know, how is it going to work in the high noise? You know, does it work? Does it work? Is noise an issue with it? Yeah, I'm seeing nods and shakes. Yeah, so it's really tricky when you get a high noise level, getting a really accurate recording, and also with patient complexity. You know, how well is the AI going to be at interpreting and translating those notes? Probably not as well when you've got your patients coming in with multi-comorbidities. So there's little evidence to date on how accurate it is. There's little evidence on its impact on provider cognitive or physical load, but providers do like them. So that, I guess, is a start. The future potential is for it to generate this plain language summary, and the thing I'm excited about is it could generate that plain language summary in lots of different languages, which would really help for the group of people I'm working with. However, people worry that it could have adverse implications for training because the junior doctors are not going to get that practice at actually taking the notes the way they normally would. So it's being used for diagnosis and prediction, so image processing and decision support. And we're starting to see AI used for system insight as well. So at Townsville Hospital, James Cook University are developing a model to predict ED waiting time, which I think will be quite useful. New South Wales thinks they've got one of those, and it's 3 hours out of date, which means it's absolutely useless. So let's see what comes out of Townsville. So there's a couple of risks for AI and EDs and considerations to think about. So the first one is the AI a continuous learning or a fixed algorithm? So a lot of AI, the algorithm's developed by a bunch of computer nerds, and then it's put in the system and then it doesn't change. So that's safer because it's been developed and tested, and you know, once you've got it, you know what you've got. But it doesn't work in a situation that's rapidly changing. So in our medical system, particularly our EDs, we're seeing a lot of change over time. And so you may need to, you know, it might be more useful to have a system that learns over time. So as you get new or different populations, the system adapts to that. If the context is dynamic and you do get a changing algorithm, you need to put monitoring systems in place though, because you don't know if it's changing in a safe way or whether it's just drifting off and doing something weird over here. So, and is there the sufficient technology infrastructure and expertise to monitor and maintain it? You need people within your hospital or even within your ED that understand the system to be able to sort out any issues that arise. And I talked before about the importance or critical importance of having sufficient funding for it to be able to keep it up to date and relevant. So the last thing I want to talk about, and it's a bit shorter today because I know that you're all probably keen to finish off the week. The last thing I want to talk about is regulatory frameworks. And it sounds a little bit dry, but just bear with me for a bit. So the one I want to talk to you about is from aviation. Now, big caveat here, healthcare is not aviation. And I can give you expertise in both of these. I've been working for 18 years in healthcare, but before I was in healthcare, I was a Royal Australian Air Force test pilot. So I spent 24 years with aviation as well. So when I say there's differences, there are definitely differences. A lot of people that just pull things from aviation to healthcare are going to come unstuck. So in aviation, the risk can be quantified, often quite accurately, because you're talking about a piece of kit, an aircraft. Things don't change over time with an aircraft. You can very accurately look at mean time between failure of equipment, and you know exactly when the thing's going to fail. In healthcare, the risk is often unknown. You see what happens when it happens. If the risk is too high in aviation, you just stop the clock. They ground the planes, they send people home or make them wait, but they just stop the clock. In healthcare, you can't pause indefinitely, and in ED, you really can't pause at all. You can't just shut your ED, you need to take whoever turns up. The demand in ED, you've got to treat all who's present, whereas the aircraft, when it's full, they close the door and that's the end of it. Aircraft teams are much smaller than the large multidisciplinary healthcare teams. Innovation in aviation is quite slow. It's about a 20-year cycle. In healthcare, it's 2 to 5 years, and with AI in healthcare, it's probably less than 2 years. There are many fewer emergencies in aviation. There are so few that when you get one, you hear about it on the evening news, whereas in healthcare, you get multiple emergencies every shift that you do. And there's great regard for human physiological limits. Fatigue is really well managed. You only fly for 8 hours and then you stop and a different crew comes in and takes over from you. And they look after you. You know, you get your meals in flight, you get plenty of toilet breaks. If you're tired, you get to go sleep and another crew member takes over. You will all know with healthcare how fatigue is not well managed at all. You're there until the job's done. You're often not fed, you don't have time to eat, you don't have time to go to the toilet. You're not well looked after in that sense. Crew and passenger safety in the aircraft is aligned. If it's bad for the passenger, it's bad for the pilot as well. Whereas in healthcare, you've often got them in conflict. I mean, think about COVID, where the health of the healthcare worker was often in opposition to the health of the patient. So you don't always have these aligned safety issues. And aviation's very process-oriented. So what I mean by that is you can follow things like checklists. It's very step-oriented. And you can use these sort of safety measures that have, checklists of regulation and standardisation and things. Healthcare, that doesn't work because you've got so much necessary variation because patients are different and every time you see something, it's probably going to be different to the time you've seen it before. So you need much more goal-oriented safety processes rather than things like checklists and steps. You need a goal of what to do and you need to be able to flex and adapt within that goal to get the job done. So with that caveat, I'm going to talk about very briefly this regulatory framework. Part of the reason I've picked it is because healthcare doesn't have one yet, which is a little worrying. So this one's come out of the EU, which is probably the leader in terms of this regulatory action. And there's a couple of aspects to it. One of them is ensuring that any AI that comes into aircraft or aviation systems is trustworthy. There has to be a trustworthiness analysis done that makes sure that all those things I talked about at the front, so making sure that privacy and data was covered, looking at transparency, looking that there's non-discrimination and that it's fair and things like that. So all that's tested before it's certified. It has to prove that it meets all those requirements. And it also has some other things. It's got this verification of design and training of the system. So they have to actually show that the system has been trained and designed effectively and in accordance with certain guidelines. They need to make sure that it's transparent. So it's not just a black box, so people understand what the system's doing. So when they see an output, they just don't go, what the heck's it doing? They can understand why it's doing it, and what inputs were related to that particular output. And finally, and this one's particular for aviation because we're getting more and more drones now and aircraft operated without pilots, and it's in everyone's interest to not have these things go rogue. So the regulation involves this human out of the loop. So if there's a human out of the loop, so if something's done remotely, then there has to be out-of-bound stops put in place. So at what point will the system come in and stop if it looks like it's going too far haywire? So you suddenly don't get, drones dropping weapons on cities and things like that. So now it's really new. The first approvals haven't come through yet, so they're only expected this year. But this type of framework is the sort of thing that I feel that we need in healthcare, so that there's some sort of regulatory action, just making sure that you don't get systems in place that are going to harm patients. So that's really it. It's a very bit of a fire hose of AI in healthcare. If you're interested in human factors, we've produced a human factors resource for healthcare people. It's an 80-page resource. It's on the QR code. It's free to download, and it's full of case studies of the sorts of issues that you might see in healthcare and whether it's a human factors issue, and if it is, the sorts of fixes that you might want to consider for that particular problem. So thank you very much.
Thank you, Robyn, and sounds amazing. I have to invite you back next year to talk about human factors. That'd be great. We had a bit of feedback then, so thank you everyone for bearing with that. We're going to try and fix it. So have a break. Fill up your glass of wine. Don't take the bottle. More sushi, and we'll be back here in about 5 to 10 minutes. So see you guys shortly.
Cool, thank you. Great, you grab that, and then I'll give you a spit. Just need to unload the opposite way to what we loaded. What did I say? Intuitive and yeah. Okay, there you go. Thank you.
Thank you.
Thank you very much.
Probably.
Thank you very much.
No, thank you, Robyn. That was brilliant. Yeah, it was great to meet you. And yeah. So please be in touch. Yeah, it'd be great. See ya.